Early studies. Physically active male conductors differed from less active bus drivers on the incidence of heart disease in a study by Morse in 1953. The problem: subjects may have been selected for the job based on body type, personality, etc. Kahn in 1963 found that potential benefits from past activity are lost after a few years. After more than 5 years of working as a clerk, former mail carriers had incidents of death from chronic heart disease equal to that of men who'd always been clerks. Problems with the early studies. Self-selection. More active people sought out the job of conductor rather than the more passive job of driver. None of the studies measured the worker's activity level off the job. Harvard Animal Study. Paffenbarger found medical records of former students, all men, dating back to 1916. They sent detailed questionnaires to men who were still living and received about 17,000 replies. The researchers took into account all activity and estimated energy expenditure per week in kilocalories. They divided the subjects into high 40% and low activity 60% groups. The least active had a 64% increased risk of heart attack over more active classmates. An energy expenditure of 2,000 kilocalories per week was the cutoff, after which there were no more benefits. It's never too late to start. A 1993 study found men who initiate moderate vigorous physical activity programs during midlife or older had 23% lower risk of death from all causes than men who did not. The Framingham study also included women. A limitation of the study was that nearly all participants reported relatively similar levels of activity. When they compared extremely inactive with extremely active, they found differences in coronary heart disease for both men and women. Nurses' Health Study, all women. The most active women, compared with sedentary women, reduced their risk of ischemic stroke by 34%. Exercise and cholesterol levels. Exercise increases HDL, good, and decreases LDL, bad cholesterol. Protection against cancer. The evidence of physical activity protecting against cancer is strongest for colorectal and breast cancer. Physical activity may affect tumor initiation and growth. Physical activity is helpful for people managing their cancer. It increases strength, aerobic fitness, and weight. It also helps manage fatigue that is often a side effect of treatment. Protection against the loss of bone density. Physical activity protects both men and women against the loss of bone mineral density, BMD. High-impact exercise, running, jumping, seems to have more benefit than lower impact, walking or Tai Chi. Control of diabetes. Exercise improves insulin resistance and seems to prevent and help manage type 2 diabetes. Exercise helps to manage type 1 diabetes. Adolescents who are more active have less cardiovascular risk. Control of cravings. Physical activity may be a useful smoking cessation aid. During temporary abstinence, physical activity acutely reduces cigarette cravings and withdrawal symptoms. Note: most research has focused on short bouts of moderate intensity physical activity. Physical activity reduces appetite and hunger. Physical activity also reduces chocolate cravings. It reduces attentional bias to chocolate images among regular snackers who are abstinent from chocolate, measured by tracking eye movements to see if the person looks longer at the target image versus neutral cues. Physical activity reduces snacking. O and Taylor in 2015 found both moderate and vigorous intensity exercise reduced the strength of desire to smoke and desire to snack during and lasted up to 10 minutes after exercise, although the response was greater in response to vigorous exercise for snacking. Psychological benefits of exercise. Few methodologically sound longitudinal studies have been performed to test causal relation, but there is a strong body of correlational work that suggests there is a link. Neither the biological or psychological mechanisms of the physical activity well-being link has been clearly established. Harris, in 1981, found people who exercise listed psychological reasons nearly as often as physical ones when asked about benefits they received. Decreased depression. When groups are compared, highly active people are usually less depressed. Both aerobic and non-aerobic exercise can reduce depression in normal, non-clinical, and clinically depressed populations alike. Non-clinical populations. A regular exercise program lowered depression among young pregnant adolescents from ethnically diverse backgrounds. Both male and female runners were significantly less depressed than non-runners. Clinical populations. Geist in 1978 assigned moderately depressed men and women either to a running group or to one or two kinds of psychotherapy, time-limited or time-unlimited. Patients who received running treatment were somewhat less depressed after treatment than those in the other two groups. Cautionary notes. At least some positive effects of exercise on mood may stem from factors associated with exercise, such as social activity and feeling of involvement with others. People may report that they feel good because they expect they should feel improvement in mood. To reduce cognitive dissonance, they may report better mood. People may feel good because they are satisfied with their performance and/or it makes them feel efficacious. Roden and Plant in 1989 manipulated the experience of self-efficacy during an exercise program by emphasizing how difficult regular exercise is and how few people are able to achieve physical fitness. Those in the efficacy condition had significantly higher perceived self-efficacy scores, and these perceptions were associated with improvements in mood and well-being. Reduced anxiety. Two types of anxiety: state, a general personality characteristic; trait, a temporary affective condition that stems from a specific situation. Morgan in 1973 found that a program of strenuous physical activity reduced state of anxiety in men and women. Buffer against stress. Many view exercise as the most effective strategy for reducing tension and eliminating a bad mood. In a prospective design of 212 girls in grades 7 through 11, Brown and Siegel in 1988 measured stressful life events, levels of exercise, and symptoms such as sore throat, diabetes, and cancer. Physical illness declined as exercise levels increased. This was consistent with later research with college women. Life stress was strongly related to illness among women with low physical fitness. Stress had little effect among women with high levels of fitness. Increased self-esteem. Sundstrom in 1984 noted that the majority of studies found a significant positive correlation between self-esteem and exercise, but few studies employed rigorous experimental designs. Even experiments he reviewed cannot prove that exercise was the sole variable responsible for gains in self-esteem. Other possible factors could be achievement of a goal, feelings of physical well-being, a sense of control over one's body, social interaction, and reinforcement from significant others. King in 1989 studied healthy sedentary middle-aged men and women randomly assigned to either a 6-month aerobic training group or control. The aerobically trained were more satisfied with their level of fitness, weight, and body shape, although they had not yet acquired increased levels of self-confidence. Hogan in 1989 found that fitness is related to feelings of self-confidence. But remember, we don't know the direction of the effect. It could be those with higher fitness feel more self-confident, or those with higher self-confidence, to begin with, are the ones who exercise more and become more fit.